attend this global integrated certificate course in nephro-urology. I feel privileged and honored to welcome our Masters of Masters, our pioneers of this course, Dr. Umesh Khanna sir and Dr. Nilesh Doshi sir, our President, Dr. Rajendra Ranawat sir, our Organizing Secretary, Dr. Dilip Trivedi sir, our Organizing Committee members, Dr. Sanjay Vani sir, Dr. Vinay Jha sir, and all other respected members. The topic for today's lecture is very important, most demanding. We commonly see these patients in our day-to-day practice. First, the topic is medical management of stone diseases by Dr. Vishwanath Billa sir. And second topic is surgical management of stone diseases by Dr. Shrikant Badwe sir. Now, from here onwards, the session will be moderated by Dr. Nilesh Doshi sir. Now, I request Dr. Nilesh Doshi sir to take over the session from here and introduce our eminent speakers.
No, I will request sir to introduce the speaker and to start the session.
So good afternoon, friends. This is our penultimate allopathic talk. Next Friday, I think, would be our last allopathic lecture, which would be on GU, genitourinary malignancies, and on hypertension and kidney disease. So this is just to remind you that we have one more Friday to go. Today, we have a very interesting and important session on stone disease for two main reasons. One, because stone disease is one of the most important treatable causes of chronic kidney disease. And second, more important for you, is that it's a disease which is probably treated a lot by even Ayurvedic practitioners as much, if not more, than the allopathic practitioners. It is something which covers both medical and surgical aspects, and therefore we have kept two speakers. Unfortunately, Dr. Vishwanath Billa had a computer problem, and his computer crashed, so all his slides and PPTs, everything crashed along with it. And if you are not a Atmanirbhar local guy, and if you have an Apple computer, it takes more than a week to get an appointment to repair an Apple computer. So that's a problem with Apple. So therefore, I will replace him. I may be a poor replacement to Dr. Vishwanath Billa, but we will do our best to try and fill in his very large shoes. But nevertheless, the buck has to stop at the course director, and therefore I am here. And since the urologist always takes precedence over nephrologist, we also decided the same, that for every successful nephrologist, there is always a urologist behind it. And after a long time, me and Shrikant are on the same platform, talking to the audience on a subject which is of common interest to both. To introduce Dr. Badwe is very difficult for me, because we've got not only a very long-standing relationship, it's been an emotional one, and we've traveled together for many years. In fact, we almost started practice together. He practiced a little earlier than me. But then if you read here, the slide says BK Kidney and GI Center. And in that BK, it is obviously Dr. Badwe, and K for Khanna was the initial BK Kidney and GI Center. My wife was a gastroenterologist, or is a gastroenterologist, and that's how it was called BK Kidney and GI Center. And even now it's called BK Kidney Center. So we have a very long partnership. I think, if not mistaken, around 18 years we worked together.
18 years, yes.
Yes. So whatever little respect I have gained in nephrology, I owe a lot and significantly to my partner, Dr. Shrikant Badwe, because the successful nephrology team is with urologists. Our fistulas were done by him. Our surgeries of all the cases which are common nephro-urology work was done by him. He, of course, is a name to reckon with in the western suburbs. Is attached to Nanavati Hospital, is also the chairman of ethics committee at the Holy Spirit Hospital, goes to a lot of hospitals in the western suburbs, used to go to almost every hospital in the western suburbs till some time back, when now you have a few more urologists in our area. More importantly, he's been very active in social circles, in our academic circles, in our associations, has been the president of Association of Medical Consultants. Obviously, he's practicing in Goregaon, so Goregaon Medical Association, Malad Medical Associations. He's held presidency at a lot of, in various bodies, including Mumbai Urology Society, and I'm obviously forgetting a lot in Indian Medical Association. He's still the trustee in the Association of Medical Consultants. But as you know, that if you keep giving introductions, then the time to speak becomes less. And therefore, without talking too much, I would invite Dr. Shrikant Badwe to give his presentation on the surgical aspects of it. And then whatever remains, I will cover up in the medical aspect of stone disease at the end of his talk. So Shrikant, we normally have 45 minutes to talk and 10-15 minutes of question answers. Give or take 5 minutes here and there. Over to you, Shrikant.
Thank you. Thank you, Umesh, for such a nice, lucid introduction, very emotional one. And at the outset, I congratulate Dr. Khanna, you and Nilesh Doshi for such a great initiative, very fantastic initiative of Global Integrated Certificate Course of NEPHRO-UROLOGY. And at the same time, I would acknowledge the supporters and sponsors of this your event. Now, our topic today, let us come to focus on our topic, today's topic. Today's topic is surgical management of stone disease. And I would say that it's an age-old wise words, and everybody has heard them, that a good surgeon is a surgeon who knows when not to operate. And that is why, you know, in spite of treatment, the topic being surgical aspects, I have written down hydrotherapy also, and will dwell upon hydrotherapy for few minutes. Second thing is that if you see over here, lithotripsy, URS, RIRS, PCA, then most of these are, you know, like pinhole surgeries or without touching the patient, like lithotripsy. So rather than calling it a surgical management, we should say interventional management of the stone disease. Now, first of all, we are going through these 4 or 5 steps: hydrotherapy, lithotripsy, ureterorhinoscopy, that is URS with rigid and flexible, retrograde intrarenal surgery, and percutaneous surgeries of various types. Now, as I said, hydrotherapy I have specially mentioned. Hydrotherapy generally is given, but always before starting hydrotherapy, one must do IVP. It is done first to assess the possibility of the stone, and of course upper tracts which are dilated, damaged, to what extent hydronephrosis is there. It is generally tried for 4 to 6 weeks. It is not tried if the stone is big and the clearance of stone passing with hydrotherapy. Generally, up to 4 mm, 90% will pass, up to 5 mm, about 70%, up to 6 mm, about 40%. And beyond 6 mm, generally we offer some kind of intervention. But remember one thing, hydrotherapy is not, you know, easygoing. Sometimes, you know, like when the patient comes with acute pain, with obstructed kidney, and at that time, we are tempted to give a good copious hydrotherapy with saline and things like that. And one must remember that it can give rise to, because of obstruction, calyceal rupture, that is, you know, cornices of the kidneys. They get ruptured, and sometimes there is perinephric collection of urine. And if the urine is infected, God forbid, if that is so, or if the patient is diabetic, it can give rise to a major problem like perinephric pus collection, fever, pulse, then hypotension and things like that. So hydrotherapy, though it sounds very, very simple, one has to be very careful while introducing hydrotherapy or taking hydrotherapy for the patient. So this is about hydrotherapy. Now let us go to your other modalities. One of them is lithotripsy. This is the classical lithotripsy machine, which quite a few of you must have seen. Otherwise, once it is worthwhile visiting. ESWL, that is lithotripsy machine, has 4 main elements. There is energy source. That energy is the one which is going to fragment the stone. There has to be focusing device because there was energy has to be concentrated, focused at the point of stone. There is a coupling device. Coupling is something where the energy to the stone, the passage, the it has to travel through that one, and that is coupling device through which the energy will travel. And most important thing is where the stone is, localization of the stone. Generally, the localization is done by ultrasound or radiographically. Nowadays, newer machines have both the facilities of ultrasound localization and, of course, X-ray localization. X-ray localization, the principle is very simple. One vertical straight line X-ray is taken and one oblique X-ray is taken, and throughout the body, the human body, we find out where the stone is, and exactly at that point, we focus the shock waves. Now, here one can see in the first place, the patient is lying over there. In second picture, you will see that is the coupling device through which the shock waves come. And in the third picture, you will see that those shock waves are concentrated where the stone is, like here. So that these are the things which are important. Now, there are some absolute contraindications, and obviously, one must not forget pregnancy, which is the absolute contraindication, and there are some relative contraindications for renal, like acute renal colic, generally it is not done. Gross obstruction, generally it is not done. If there is infection, absolute no. One should be very, very careful, because when you are doing lithotripsy, you are fragmenting the stone with the shock waves, and those stone pieces, they, like scatter everywhere. And that infected urine can give rise to, bacteremia or septicemia. It can go into blood. Declining renal function. See, first and foremost thing is that after doing lithotripsy, you are totally depending on the function of the kidney, which will going to produce copious amount of urine, and that urine is going to pass those fragments of stone which you have created by a shock wave, and those fragments have to pass further. So in a declining renal function, obviously, you could do a good fragmentation, but clearance of stone is going to be far difficult. Then significant hematuria, again, is a contraindication, because hematuria means there are some blood vessels, some veins, or some of the areas which are open, and through which infected urine can give rise to bacteremia. Then patients who are anticoagulant treatment, because these shock waves would create intratubular, some amount of hemorrhage. And if the patient is some amount of hemorrhage, because it is fragmenting the stone, and if the patient is on anticoagulants, it can give rise to intrarenal or perirenal big hematomas, and that can be a big problem for treatment. Another thing which probably I've forgotten is calacial diverticular stones. Many times there have been many instances, and patients have been very unhappy, and they have had a fight with the treating urologist, when probably the stone was treated, which was in a calacial diverticulum. And in the diverticulum, the stone will not get fragmented well, and being a diverticulum, obviously, drainage of those fragments will never occur. So calacial diverticulum is again contraindication for using ESWL. Then what can be the sequelae or complications of ESWL? Because I have said sequelae because not everything is complication. Some of the things are expected. Now for hematuria, it is quite common, it is expected. And I tell my patients that if hematuria is not there after ESWL, rest assured that your stone is not fragmented well, obviously. Because if the stone gets fragmented, if it goes into pieces, it is going to cause some amount of hematuria. So it is a quite common thing. Antibiotics are recommended for short term, and one has to observe, give diuretics. Incomplete stone fragmentation and obstruction, quite a common thing, because that is why there is a limitation for ESWL. One should do ESWL for stones which are less than 2 centimeters, preferably 1 to 1.5 centimeters. Because the larger the stone, the fragments which are created are larger, and sometimes those fragments themselves will cause obstruction. Then there is one very interesting entity in ESWL which is known as Steinstrasse, that is stone street. Stein means stone and Strasse means this one street. in Germany, and the machine was invented in Germany. So this entity is called Steinstrasse, that is roadblock, and it is usually due to larger fragment which is at the tip, and all small fragment they get accumulated. I'll show you a good picture of Steinstrasse. And for such kind of large stone, that is why before doing lithotripsy, it is advisable to put in a stent, of which I am going to talk a little more later on, because stents are the boon to urologist and of course nephrologist also. Now this picture, if you see, there is a Steinstrasse, a big stone was fragmented, and I hope you are seeing my this one, the whole this ureter along the stent, there are all pieces of fragmented stone. Now, this kind of Steinstrasse, if it happens, one has to go in sometimes with ureteroscopy or to clear them. And if there is a stent, sometimes the emergency does not occur. Nowadays, in lithotripsy, few things we do, that is preemptive analgesia, like patients who are taken for lithotripsy. Normally, patients are told nothing is given, and it is you take a lithotripsy and go home in 1 hour, etc., etc. But one should remember that nowadays we give some amount of analgesia, anesthesia standby we keep, and analogous sedation helps, because then the patient does not move and fragmentation is much better. Then post lithotripsy, we always put them on alpha-1 blocker, which increases the chances of spontaneous passage of stone fragments. And for better success, follow strict criteria, which included, which I told you, like some of the contraindications, and second thing, the this one, size of the stone. But remember one thing, indications of lithotripsy are decreasing all over the world due to tremendous advantages in endourological procedures, which we are now coming to. So presently, the role of lithotripsy is getting narrower and narrower and narrower, and less people are using lithotripsy, but all the same, it deserves mention because it is one of the important modality. Now, just now I said about stent. So there is ureteric stent means what? That stent means there is a tube inside, like cardiac stent, like stent anywhere else. Here, if there is a stone, we bypass the stone with a stent, and the stent is called double J because one of the J of the stent, it remains in the kidney, which is seen here, and second J of the stent comes into the bladder, and that is why the name itself calls it DJ stent, double J stent. And double J stent has given us, it's a boon to urologists and nephrologists. It is helpful to drain the obstructed kidney, to drain the pyonephrotic pus from the kidney, to improve the renal function and control the infection, because obstructed kidney with infection with like diabetes or comorbidities, stent is a boon, and the patients, they recover faster, very early, faster. Pre-treatment of RIRS, which we are going to discuss later on. These are the endourological procedures, endoscopic procedures. So before doing RIRS, we require to put stent to dilate the ureters. And of course, post-treatment, after doing lithotripsy or after doing PCNL, everything to avoid obstruction, and post-treatment to drain the residual fragments and to drain the obstructed or infected kidney. So DJ stent, in short, is a boon, and it has been used everywhere in the urology and nephrology. Now that is where we come to ureteroscopy. It is done for the ureteric stone. The calculus is read by a special telescope, and the stone is fragmented by variety of energies which person would have. Now these scopes, they started with 12 French. Our ureters are around 4 French, 4 to 5 French. The scopes initially which were available were 12 French, then later on 8 French, later on 6 French, and now even a 4 French scope is available. 4 French means the size of the scope is of a size of the ureter. So obviously they are becoming safer and safer, and energy sources also. Initially we used to use mechanical energy and blast the stone. Nowadays lasers are available, ultrasonic fragmentation is available. These are finer instruments or finer modalities which can give rise to much better fragmentation. So the scopes are rigid scopes, and they go through the telescope. That scope goes through the urethra, female urethra or male urethra, enter into the bladder, and in the bladder, once you see the ureteric orifice, you enter ureteric orifice and reach up to the stone. And once you reach there, with whatever energy source you have, laser or whatever, you can fragment the stone. Here there is a stone, and this is the scope which has reached over there. Now here again, as I said, the energy source, variety of energy sources are available. Now holmium laser has come into picture, and that again is a boon for ureteroscopy, because some of the procedures in ureteroscopy, in a finer instrument, you cannot put in forceps to grab the stone. You cannot put in an instrument with which you can hammer the stone. So basically, these finer and finer instruments, they require holmium laser mandatory. It is mandatory to have it. For example, flexible scope. Holmium laser has a fiber. So flexible scope, no rigid instrument can go in. So flexible scopy is always with holmium laser. There is one more laser which has come nowadays, which is known as KTP laser. So both these lasers are used for fragmentation of the stone. What happens with holmium laser is a precise fragmentation, pulverization, that is, depending on the energy which you use in the laser, you can pulverize it. You can convert that stone into absolutely powder, what you apply to your face. There is no upward migration. When you are doing mechanically, sometimes the stone will migrate upwards into the kidney, and then you can't do anything. Then you are helpless. So upward migration or movement of the stone is hardly any with laser. It reduces the need of stent, because like when you are using higher caliber instruments, and when you are using energies which are mechanical energies, then you need to keep a stent. So if you do it with laser, it is such a smooth go that many times stent is also not required. And as some time back only I mentioned, whenever you are using flexible scope, no rigid instrument can go through it, and for flexible scopy, the laser is mandatory. This is what flexible scope is. It is the special fine scope whose tip is flexible. And how much flexible? 360 degrees almost. It can completely bend, and it can enter into any nook and corner of the kidney. Look at this. Now it has gone into the upper calyx. Now you bend it and it can enter into the inferior calyx. So it goes into various areas. This again shows the same thing. And it's a big advantage if you are using flexible scope in morbid patient, morbid obesity, or those who have coagulopathy. Then it is a extremely big boon in ectopic or mal-rotated kidneys, because ectopic kidneys, mal-rotated kidneys, rigid instruments are quite dangerous. Now in this figure, I have shown at various places the stone. It can go up, it can go in the middle calyx, it can go into the lower calyx, it can move around in the kidney, and every nook and corner can be inspected. What are the indications? When do we use these retrograde intrarenal surgery, especially proximal ureteric stone? When you go with rigid instrument, you start blasting the stone, you start fragmenting the stone, and one or two big pieces, they would fly off upwards into the kidney in the proximal ureter. And then what would you do? So that is the time when you require this flexible scope and retrograde surgery. It is known as retrograde because you are going from lower end into the kidney. So retrograde we are going. Then diverticular stone, as I told you in the lithotripsy, when we were discussing lithotripsy, that diverticular stones, there is a very narrow opening of the diverticulum. So with this RIRS, you can go up to that end, and in fact, with the laser, you can open up the stenosed, this one, calyceal neck of that diverticulum. You can open it up with laser fiber and go inside and fragment the stone. Residual stones after procedure. Sometimes procedures are done. Let us take example of ESWL. ESWL is done. 90% of the stone fragments have passed out and few fragments are remaining. You require RIRS. And to ensure stone clearance for employment in certain professions like pilots or people who work on sea, navy, etc. Because they are not given job even for a smallest size stone like 4 millimeter, 6 millimeter, which normally we would conserve and tell patients that wait and watch. But for them, it's a question of उनका महीने के पगार का question रहता है, so you do it and clear them off of the fragment stones. This again is a good picture to show you. See, this is the stone. If it was blasted, small stone, it is in the calaceal diverticulum. If it would have blasted with lithotripsy, the fragments would not come because it is here. Now look at it. This is the flexible scope which has reached up to the neck. It has entered into it, and this is the picture where it has completely cleared the calyx of the stone. This URS video I wish to show you, but I would say that rather than like disrupting our flow, I will show you URS at the end. Let us see. So another important procedure, extremely important procedure, probably in today's world, in today's urologist, does the largest number of stones or maximum number of patients they do tackle with PCNL. So PCNL, when you enter into the kidney, it is known as percutaneous nephrolithotomy. Percutaneous is from the skin you enter inside, nephro is kidney and litho is stone. So percutaneous nephrolithotomy. Now, done in cases where the stone load is more, 1.5 centimeter or more, 2, 3, 4, even in very large Stagon calculus also, one can do PCNL and one can enter into the kidney through various calyces and do the clearance. Now, PCNL has 4 main things which have to be there. One is percutaneous access to the renal collecting system. The stone is in the kidney. So first and foremost thing is that you have to enter into the kidney from the skin. So there is percutaneous access to reach the kidney. Afterwards, once you reach the kidney, you dilate the tract because you want to pass a good scope, telescope, some instrument to fragment it, to remove the stone. So the tract has to be dilated. After that, once you see the stone, you need to fragment it. So you require some kind of energy, some kind of instruments and fragment the stone. After that, you require various instruments to pick up the fragmented stones. And after doing all that, the kidney has to be drained properly. So these are the 5 main steps of PCNL. Now this PCNL video, Pallavi is there because this is the important video which I want to show. Pallavi?
Sir.
Pallavi, you are around?
Yes, she's there. I heard her voice. Pallavi, you have to start the video.
सर आप स्टॉप शेयर कर दीजिए और फिर
1 minute, I have done stop share.
हाँ अभी डेस्कटॉप पे जाके फिर से आप स्क्रीन शेयर कर दीजिए
बोलो जल्दी
शेयर स्क्रीन कर लीजिए
करेक्ट शेयर स्क्रीन किया
और जैसे आपने पहले ओपन किया वैसे ही करना है
स्क्रीन के ऊपर दबना है ना
हाँ हाँ शेयर स्क्रीन करो
शेयर स्क्रीन करो
आएगा
आगे स्टॉप शेयर
डेस्कटॉप पे जाइए आप
शेयर स्क्रीन डेस्कटॉप पे कैसा जाने का वो बोलो मुझे अभी
सर आपने जैसे पहला ओपन किया था ना वैसे ही जाना है आपको
कैसे करने का स्क्रीन के ऊपर डबल क्लिक करूं
हाँ करो
desktop is not coming PCNL video gone. It had come very well initially. 1 second, we'll try it only once now. Share
close करो
no problem.
Share screen किया we have to go to screen ना पल्लवी
सर आप मुझे वीडियो भेज देते हैं क्या मैं आपका ओपन कर लेती हूँ यहाँ से
मैं अभी कैसे भेजूं तुमको किसके ऊपर भेजूं नहीं वो वीडियो जाएगा
व्हाट्सएप करो ना
इतना इजी नहीं है
अच्छा
पल्लवी इतना इजी नहीं है वीडियो भेजना
सर
मेरा डेस्कटॉप क्यों नहीं आ रहा है इतना खाली बोलो डेस्कटॉप आएगा तो 2 मिनट में हो जाएगा
सर बाजू में ऑप्शन रहेगा ना स्क्रीन के बाजू में ऑप्शन रहेगा डेस्कटॉप का
व्हाइट बोर्ड लिखा है पावर पॉइंट स्लाइड शो फाइनल पीपीटी माइक्रोसॉफ्ट फाइनल पीपीटी स्काइप पे आईफोन पैड डेस्कटॉप का ऑप्शन किधर है गरे नहीं है
सर रहेगा उस पर ही
यू मस्ट बी सीइंग माय स्क्रीन ना
नो आई थिंक वी आर सीइंग यू ओनली स्क्रीन अभी स्टार्टेड स्क्रीन शेयरिंग ओके
व्हाइट बोर्ड पे क्लिक करो,
इसके ऊपर
व्हाइट बोर्ड पे।
व्हाइट बोर्ड, बॉटम पैनल किसी ने लिखा है, देख, इट इज इन द बॉटम पैनल।
नहीं देखा मैंने वो।
डाउनलोड,
नहीं जाने दो अभी। Anyway, we'll go ahead and at the end of the presentation.
Rohini, meanwhile, you can try sending it to her, Pallavi ko, towards the end from another place.
It doesn't go.
It is too heavy. Yeah, it's difficult. I agree with you.
okay.
It is heavy generally.
Yeah, it is.
Anyway, I'll do one thing. We'll go to the lecture, and at the end of the lecture, completely we'll go back.
Yeah, or later on also, while I will be taking the talk, you can still think of whether it's possible. We can interrupt.
Now see, these are the multiple tracks of PCNL. You can see in this picture, it's a large trigon, and looking at the axes which we have created to reach over there. So one of these one will go from the upper calyx, second one has gone through the middle calyx, the third one has gone from some other calyx, and this stone was completely clear. Now the slides are not moving. Then another thing in PCNL, another thing which has helped us is flexible nephroscope, cystopnephroskop. So these are the scopes. After doing PCNL, if there are some pieces in some calyces, just now I showed you that trigon was treated by 5 different, axes. So instead of that, with this kind of a flexible scope, from the same 1 or 2 axes only, you can enter inside, go in the various parts of the kidney, and if you have a laser, you fragment the stone. So this flexible nephroscope is another additional boon to us for complete clearance of the stone. Now, bladder stone, it is one of the most primitive things. All of us will do it. We go inside, and most of the time, the smaller stones are done by mechanically crushing it, and the bigger stones, again over there, we enter in the bladder percutaneously, not through urethra, percutaneously, make the bladder full, like PCNL, like what you enter into the kidney, make the bladder full, go inside the bladder from suprapubic region, dilate the tract, go inside with nephroscope, and again, the very large and very hard stone, also you can blast it well. So, in short, any stone, anywhere in the urinary tract of any size and any number can be removed in a patient in a very friendly manner. Nowadays, open surgery has got very, 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 very limited role, but still, we people who have done it, mastered the technique, sometimes we use it in difficult situations. But these are the things which were more important. So without open surgery, endoscopically, almost all can be managed. And our Hippocrates' fourth word, I will not cut person laboring under the pain of stone, and leave this to be done by men who are practitioners of this specialized work, and that is us, urologists. Thank you. Now, Pallavi, if you can help me, if I can get my presentation on the board, the same thing should be possible for one video. That video we can show, because that is quite an interesting video, and it will give, like good information. So I will try it once again, Umesh. Is it okay?
You can take your time, no problem at all.
Yes, sir. There is a suggestion that you stop screen sharing and open the video on your desktop and then share your screen. Then we will be able to see the video. So you stop.
Stop Guru, Hare Bapre.
Stop screen sharing.
Understand why it is happening, because if I can get my this one, if I could get my presentation from desktop to this, video should be the same way, na? Very easy. It should be. Now, what were you saying? Leave.
सर ऑप्टिमाइज वीडियो करके ऑप्शन रहेगा, स्क्रीन आप शेयर करेंगे ना तभी नीचे ही है,
शेयर स्क्रीन किया.
स्क्रीन पे क्लिक कीजिए.
ऑप्टिमाइज स्क्रीन शेयरिंग फॉर वीडियो क्लिप.
हाँ
किया मैंने. शेयर. No. I need to go. See, it's a very simple thing. I need to go out of this onto my desktop, which I have done n number of times in my previous lectures. Somebody is saying that first
you start your video first, but basically you want to go on your desktop. I think you leave and come back whenever you want. Mine is a filler, so not a problem. Have you left?
Yes, sir.
Okay, so audience, what did Dr. Badwe say? He said that more than 6 millimeter stone, it will be difficult to try medical line of treatment, and it is best to try intervention. The other area he touched upon was hydrotherapy, which was always thought of as a very good method of removing stone. And we used to admit the patient, give 6 to 8 bottles of fluids, give diuretics, make him pass a lot of urine. Sometimes can increase the pain, sometimes cause perinephric collection of fluid and rupture calyceal area and so on. So urinoma can develop. So these are the two lessons that we learned. The other one he talked about was, although ESWL was the first one which really created a revolution. Is the audience able to hear me? Nilesh, I think.
Yes, sir. Very
okay. Well. So it created a revolution. The ESWL is slowly going down in its reputation and in its usage, mainly because the usage is now limited to only a few areas. And when you do ESWL, there could sometimes be remnant stone remaining. Sometimes it is painful while doing. Sometimes there is hematuria. Sometimes there is mild renal injury. There used to be earlier worries of hypertension development and renal insufficiency, but that is now considered as not really a big problem. So it's not that it is damaging to the kidney. It's in general, you have better methodologies available. So by the time I think Dr. Badwe is struggling with his video, can I start my presentation, and then if Dr. Badwe gets his video, we can take it later on?
Yes, sir. Yeah, you continue with this.
Yeah, I think in which case...
I suppose we can do one more thing, sir. We have one speaker, Dr. Shippy Shukla, okay, from Himalaya company. Can we finish it off?
Yeah, no problem.
Yeah,
so short thing
short
we can take it
presentation of Himalaya Pharmaceutical Company.
Yes.
So Pallavi, Dr.
Is
Shukla.
He around?
Yeah, but Dr. Shukla himself will take care of it. No? So Dr. Shukla.
Good afternoon, sir.
Dr. Shukla, good afternoon. You can start in between if Dr. Badwe comes. We will.
So it's my great pleasure and privilege to have a Dr. Shippy Shukla. When he called me up yesterday that I am Dr. Shippy Shukla calling, I was shocked and surprised that how can this be? Because he was one of the stalwarts in the field of Ayurveda. Am I correct, sir? He was from Jamnagar.
Yes.
Was a stalwart. So first I surprised, but then immediately I woke up and recollected. No, it's not. It cannot be so. So he is the the head of the north side of Himalaya Pharmaceutical Company, and he is going to have a small presentation on behalf of Himalaya, who are the sponsor of today's event. Over to you, Dr. Shukla.
So slides are visible?
Yes, sir. Very good.
Okay. So, namaste and good evening, everyone. Thank you so much, Dr. Doshi, sir, for the kind introduction. Indeed, it's a great pleasure and honor for me to be part of this knowledge sharing session known as a integrated course in NEPHRO-UROLOgy organized by the AppCon. And thanks to technology and the team behind this organizing this event, which made this possible even in this pandemic time. And in fact, our speakers, they have given valuable advice on surgical management option. And in fact, Dr. Khanna, he has highlighted importance about the medical management. At Himalayan, we are celebrating the 90th year of trust with a vision of wellness in every home and happiness in every heart. And since 1930, like we have been driven by research and remained focused on delivering life-changing medicines that are contributing value to the patient and society. Today, I would like to discuss about the holistic approach in the management of urolithiasis. As we know that the urolithiasis is an age-old disease, as in fact, Dr. Burdway, he was also talking about the time from the Hippocrates. And the data, as we know, around it affects around 10 to 12% of population around the world. And this incidence varies from the country to country. At the Himalayan Drug Company, like we are pioneering the medical management of urolithiasis, and for more than 7 decades, we have introduced our cystone in 1943. So to fortify the management of urolithiasis, today I would like to present cystone 4, which is packed with the herbs posing lithotriptic and spasmolytic action, and it expels kidney stones and prevent recurrence. Since it's a polyherbal formulation, it contains various time-tested herbs which have been widely documented for their benefit. And one of the ingredients that is Silapuspa is there, which is Didymocarpus pedicellata, which has got excellent lithotriptic property because of these active ingredients like Didymocarpal is there, which prevents the dissipation, accumulation, and supersaturation of calculogenic chemicals in the urine. Similarly, another ingredient that is Pasan Bheda, which has got anti-lithitic activity. So in fact, it prevents the stone formation process also. And this one active ingredient that is Burgenin is there, which has been widely documented for its benefit, which also this herb which corrects the crystallite colloid balance as well. And the third most important ingredient that is Gokchura Tribulus terrestris is there. And there are many active ingredients, and it prevents the deposition, accumulation, supersaturation, calculogenic substances in the urine, and also has got antilytic property. Nagarmusta, that is Cyprus scariosis, which has got diuretic property, and it shows diuretic activity in many of the studies, and it's useful in the urinary complaints. Now, since the time is short, I have summarized my presentation in a few slides. If we talk about the benefit of the cystone 4, actually it works on different aspects, and this actually corrects the crystallite colloid imbalance. That is one of the benefits. And by that, we are able to get benefit. It also soothes the inflamed tissue and prevents implantation also. And this also cystone 4 will dissolve mucin, which binds stone particles and flushes stone by promoting diuresis, and exerts spasmolytic action on the to enable a smooth expulsion of the stone also. So that is all the few important benefit of the cystone 4. Also this, because once there is a more oxalate production, which converts into the, which leads to the stone formation, and also this cystone 4, what it does actually, it also inhibiting glycolate oxidase enzyme, because this glycolate which convert into the glycoxylate in presence of this enzyme. So this cystone 4 which inhibits the enzyme, and we are able to reduce this oxalate, and calcium oxalate particularly, we are able to reduce the chances of that. So these are the few important benefit. It has been tested in the experimental studies also in rats, and there we have found that cystone formulation particularly inhibit this enzyme activity, and by that we are able to reduce this oxalate form. There are many studies also. Because of the time constraint, I have put only one over here in my presentation, that evaluation of efficacy and safety of a herbal formulation, cystone 4, in the management of urolithiasis, which was done by Dr. Jayaraman R. And this study, which was published in Journal of Urology and Research. And this study, 65 patients were enrolled, and 2 tablets twice a day cystone 4 was given for a period of 3 months. And this was the age mean 36.77. And the result of the study, which shows that size of the calculi, because we have divided all the patients till 7 to 12 mm size, where the complete expulsion by stone was 53.3% patients, and in rest of the patient there was a statistically significant reduction which was recorded. So this is all in the patient who had a stone size 7 to 12 mm, there is 53.3% complete expulsion, and in rest of the patient there was a significant reduction. And the patients of 5 to 6.9 mm, there the complete expulsion was 57.1%, and rest of the patient there was a significant reduction in the size of the stone. Apart from also the clinical symptoms like effects of the stone fort in expelling large size calculi, there also we can say this colic pain at the loin, hematuria, dysuria, nausea, vomiting, and painful micturition. We have got very promising result by using this stone fort in all these patients. So these are the few important findings of this trial which was done. To conclude this, yes, this stone fort which exhibit anti-lethatic activity by correcting this crystallite chloride imbalance. It also has got poses lithotriptic action by dissolving the mucin that binds the stone particles, offers diuretic action as well, and exhibit spasmolytic activity also. So these are the few important benefits of this stone fort. In the stone fort, particularly this word fort, which stands for the faster dissolution, for the offers quick relief, reduce recurrence also, and treats larger kidney stones as well, and economical also. So this is we can also reduce the cost of therapy also to the patient. It is indicated in the patients of urolithiasis, urinary stones up to 12 mm, in fact, because in this study we have enrolled the patients whose stone size validity 12 mm, and also in crystalluria, dose that is 2 tablets twice a day can be given. So with this, I would like to conclude my presentation, and once again, I would like to thank Dr. Khanna sir, Dr. Nilesh Doshi sir, and whole organizing committee. Taking this program even in this pandemic time, really appreciable. Thank you so much for providing me opportunity, sir. Thanks a lot. Thank you so much, sir.
Thank you very much, Dr. Shukla sir. Convey our regards to Dr. Srikant sir as well as Jiyandani sir for supporting this event, and we hope that this patronage will continue in future also.
Yeah, for sure.
Thank you
sir.
so much.
Thank
sir.
you. Thank you so much, sir. Namaste.
So, Badwe sir, are you fine now or?
सर उनका नेटवर्क का इश्यू आ रहा है.
Okay, sir. Khanna sir, I don't think so that sir needs the introduction.
No.
So,
but I might need screen sharing ke time pe. No, I'm there. Yeah. Fortunately, the screen sharing is always a 5-minute ka dar.
It's always a pleasure to have the, yeah.
वो बाउल किधर गया? This one. Yes, I'm there.
Yeah, sir. Very well.
I'm visible, I'm audible, but the slide is showing Dr. Suraj Suchak. So, Dr. Suraj Suchak is a urologist who will be taking the next talk on next Friday on genitourinary tract malignancies. Now, since my talk was to be taken by Dr. Vishwanath Billa, and late at night he told me that he is unable to take it, I needed a few slides, and then I would add up a few more of mine and eventually make a small talk for today, so that we can handle the evaluation and management of urolithiasis from the medical point of view. So, see what is the diagram showing? I think somebody is talking of loin pain. So every loin pain is not a stone. Okay, that is what it meant. So they say that if you throw stones, there are some people who make milestones out of it. And me and Dr. Badwe, we had a hospital called BK Kidney and Center. So we took out the stones and made a museum out of it. So Dr. Badwe has a kind of a cupboard where different kinds of stones are actually depicted. So what we are trying to show you that the stones could be a different color, shape, hue, consistency, shape, design, whatever you call it. Why this talk? Today we are having this talk because, as I said in the beginning only, that stone disease is an important treatable cause of CKD. It is sad to have somebody on dialysis and transplant just because he had a stone disease which we missed and we did not treat. And you must remember that India is in the stone belt. So that is why this talk is important. And as I said earlier, it's important because it's treatable. How frequently it is? 11% of men and 7% of women have at least one episode of stone in their lifetime. It's generally more common in the, earning age group, 40 to 50 years, the breadwinning age group. So it's important because you may lose important time in months and years with intermittent episodes of chutti and surgery and infection. And sometimes it can lead to a lot of complications. It can be a part of a systemic metabolic disease. So you thought there is a stone, but it turns out that you have a metabolic disease, or you may have predisposing metabolic risk factors. So you diagnose a stone, and as they say, that you can hit two birds with one stone. That means you can diagnose an entire metabolic syndrome and save the body from various problems by just diagnosing a stone. So you can pick up a metabolic disease. All these are my slides. The prevalence is variable. In some countries like in Gulf, especially Saudi Arabia, it's almost 20%. And the same is in India, Pakistan, Afghanistan, the prevalence is high. It's not the same percentage, but the prevalence is high because we are, especially in the northern part of India, it comes in the stone belt, and I think Rajasthan has the highest in our country. Why is the stone numbers increasing? The prevalence is going up. And there are various factors, and this is important paragraph because it will come again and again. From history to treatment, everywhere this will come. So global warming is one of the reasons why stones are increasing. And so climate care is important. Low water intake, and you will again see why again and again low water intake is important. Surprisingly, low calcium intake. A lot of people feel that you should not give calcium, but actually low calcium intake is a cause of calcium oxalate stones. And of course, one of the major reasons why stone disease is increasing is obesity. High fructose intake, animal protein intake, and this is of course not so important in our country, but more important abroad. But in our country, what is important is high salt intake. We are a very high salt consuming nation. Our intake of salt is more than 10 grams. In certain parts, 12 to 14 grams. You will see a lot of bariatric surgeries now going on. Obviously, if obesity is high, bariatric surgery is high. And the short bowel syndrome and whatever bariatric surgery will make you prone to oxalate stones. If those who attended last Friday's talk, I had brought out the topic of drugs and kidney, and one of the slides had shown crystal-induced acute kidney injury. So there are certain drugs like phosphate enemas if you give, indinavir, ciprofloxacin, levofloxacin. Many of these drugs can cause crystal-induced acute kidney injury. There are stones. Apart from this, we also talked about how herbominerals and oxalate stone formation. And of course, hereditary causes and strong family history are the main predisposing factors of who will form a stone, who will not form. This is that karmic area. Apne karma mein likha hai, hereditary and family history. So is stone disease or is nephrolithiasis a systemic disease? Yes. Gout and stone, hyperparathyroidism and stone, renal tubular acidosis and stone, cystinosis and stone, and these are all metabolic diseases. These are all systemic diseases. Crohn's disease and other inflammatory bowel diseases. Obesity we discussed, and you would be surprised to know how diabetes predisposes to stone formation. Because it causes insulin resistance, it leads to hypercalciuria, and with hypercalciuria, you can have calcium stones. Also, when you give insulin large doses, it can cause acidic urine and uric acid stones. And as I mentioned, drugs and herbominerals. And we did touch upon, I don't know whether every one of you attended it, but we did touch upon a lot of vegetables, a lot of fruits, a lot of herbominerals caused oxalate toxicity. In general, stones can be classified into calcium containing stones and non-calcium containing. Roughly about 70 to 80% are all calcium containing stones, and the non-calcium ones are the remaining 20 to 25% stones. Or generally calcium stones are radiopaque, and generally non-calcium ones are radiolucent except cystine stones. So the stones are predominantly, if they are calcium stones, they are calcium oxalate, calcium phosphate, or both. You could have triple phosphate or struvite, which is the infection wala stones, which form about 10%. And uric acid stones again form 5 to 10%. Then you have rare cystine and drug-induced crystals and indinavir and triamterene. These are again drugs. So again, what are the predisposing factors? I think the risk factors for calcium stone formation. Okay. As I told you, that last paragraph, it will come again and again. Age, yes, 40 to 50 years. Gender, male. Season, we know, hot season. Any fool will tell you that during summer season, his colics increase, his stones increase, and during winter and rainy season, he passes stones. Fluid intake, we know that anything less than 1 liter, you are definitely prone to stone formation. Between 1 to 1.5 liters. Those who have a tendency for recurrent stones, they will form stones. And beyond 2.5 liters, basically a urine output of 2 liters, you have lesser chances of developing. That means so much of fluid intake that you pass a urine of 2 to 2.5 liters, then you have lesser. Diet we just discussed, and we will be discussing again and again that how in a small percentage of cases, diet would play a very important role, especially uric acid stones and oxalate stones. Occupation will come in the next slide, how it makes you prone to develop stone. Bedridden patients, again, the bone mobilization of calcium. So mobility is important. Bedridden will make you more prone to stone disease. And we just touched upon a whole list of 7 to 8 metabolic disorders. And as I said, that if you have an anatomical defect, then you're more likely to develop stone. For example, horseshoe kidney and polycystic kidneys. These are anatomical defects, and they will be making you more prone to develop stone. And family history, you will see in a lot of people, they have a family history of stone disease. I was talking of occupation. So basically occupation, again, it can lead to low urine volume and urolithiasis. So what happens is, if you're a taxi driver, a chauffeur, a chef, a kitchen worker, you get less chance to go to the toilet to pass urine. So what you do is you take prophylactic measures of drinking less water. So a lot of people, they in certain professions, they drink less water and they have more tendency for stone formation. So certain occupations are also making you prone. So as I mentioned, again, these are the list of all the urinary risk factors for stone formation. So low urine volume, less than 1 liter. Alteration in urine pH. So extreme acidic pH, that is pH less than 5.5, uric acid stones. Highly alkaline pH, more than 7.5, then you have calcium stones, you have cystine, you have hypercalciuria. If you pass more than say 240 to 260 milligrams of calcium in the urine per day, that is 4 per kg and more, then that's hypercalciuria. Similarly, hyperoxaluria, in a day you pass more than around 45-50 milligrams. Hyperuricosuria, that means your uric acid in the urine per day is more than 600 milligrams, and very little citrate if you pass in the urine, less than 250 milligrams, or you pass very little magnesium in the urine, less than 50 milligrams, then these are the urinary risk factors for stone formation. Now, why is it important? Because when you do a metabolic analysis of patients who form recurrent stones, these figures are important, these tests are important, and you do your urine metabolic profile, wherein you measure the calcium in the urine, the oxalate in the urine, the citrate, the uric acid, and so on. So how are stones formed? You must be wondering, Baba, ye stone hota kyun hai? So supposing this is the stone formed, then prior to it, you have a lot of abnormal crystalluria. And these abnormal crystals come because of one, there is supersaturation of calcium, oxalate, you have alkaline pH, you have very little urine. So when these four factors come together, it aids in supersaturation. Then there are inhibitors which inhibit supersaturation. These inhibitors are citrate, magnesium, and so on. If you have less of these inhibitors, then obviously these get an upper hand, supersaturators, and so your abnormal crystalluria becomes stone. And then there are certain promoters who help in it. क्या बोलते हैं? Catalyst they become, काड़ी लगाते हैं. This is uric acid. So on the base of uric acid, you could get a calcium stone formation. So all this converts abnormal crystals into stone. But to begin with, you must have all of these predisposing factors, which is again revision. I am telling you that last paragraph was important. Age, male, garmi ka time, climate, less fluid, stress, affluence, paise wala, set, pet aage, obesity, diabetes, diet which is rich in meat, salt, etc., metabolic disorders, gout, diabetes, etc., karmic, family history, anatomical defects, polycystic kidney, etc. So all this comes together and helps in stone formation. This is how the calcium stone is formed. This is, of course, for the infection stone, infected stone formation. Here, your urinary tract is basically infected with a urea splitting organism. This is a special variety of infection. And from here, various factors add on to it, eventually leading to crystalluria and infection related stones. So what happens is the urinary ammonia बढ़ जाता है, urinary pH बढ़ जाता है, it becomes highly alkaline. Citrate कम रहता है. Citrate is a good thing to have. That is why you give potassium citrate. And all this helps in increase in the calcium phosphorus product and agglomeration of nucleation, abnormal crystalluria, and stone formation. Let's take this one. This is, I think it's about uric acid stone formation. So uric acid stone formation, again, eventually you have a stone, but before that you have abnormal crystals. Mainly the crystals are abnormal because of uric acid supersaturation. Uric acid was supposed to be dissolved, but instead of dissolving, it becomes supersaturated and becomes crystals and therefore stones. So to get supersaturated, obviously you must have a lot of uric acid in the urine. There should be acidic pH, only then it precipitates. And there should be less urine because then only it helps in precipitation. So these three factors, when they come together, they lead to uric acid supersaturation, which causes abnormal crystalluria of uric acids and then stone. But for all these to happen, you must have again gout or some other metabolic disorders, family history, genetic tendency to form more uric acid, predominantly male sex. Your diet should be rich in proteins, and that's what your purine should be high. Your ammonia production in the kidney should be less, and that is what would lead to acidosis. And your acids which are produced in non-veg food, there is a lot of dietary acid in non-veg food, which is why hum log CKD mein na bolte. Why do we say no to non-veg food in CKD? Because it produces a lot of acids, sulfur containing and other kinds of acids. And of course, it should be mixed with a less fluid intake, or garmi mein sweating and fluid loss, or very high temperatures as in Gulf, Rajasthan, etc., etc. So this is how, if all the bad forces come together, then you have stone formation. The same is with cystine stone. For cystine to become supersaturated, you must have excessive urinary cystine. Probably you must have a metabolic syndrome wherein there is high cystine. Your tubules should absorb less of cystine, and that is how the cystine stone forms. So much from understanding how stones are formed. Now, once stone history is there, or once you have somebody coming to the casualty or coming to your family practice with a history of colic. So, a colic ki pain leke patient aaya, what all you will do to evaluate. We will go step by step later on, but this one slide tells you a lot of things. So most important is history, whether this colic is typical loin to groin or loin set goes down to the testicles, whether there is dysuria, whether it irritates the urinary passage. All this is typical history. And you know in medicine that everything is not always typical. So there are red herrings, and you've seen a lot of appendicitis presenting like stone, especially in children. And some of the stones get their appendix out, not realizing that it was actually a ureteric colic and so on. So the history is important in diagnosing a ureteric colic or a stone, and whether the hematuria, which is silent, is it a malignancy or it is a silent stone, and you pick up from a CT that it was a stone, so on. So history taking is important. But from the history, you also come to know about the risk factors. We just enumerated the risk factors, and the history will tell you whether he has recurrent episodes of gouty toe, gouty arthritis, gouty tophi, whether he's eating a lot of non-veg, whether he's a salt eater, whether he's got diabetes, whether he has inflammatory bowel syndrome, whether he's undergone a bariatric surgery. So the history of risk factors is also important. From the risk factors, you know whether he has a higher tendency to develop recurrent stone formations. From the risk factors, you know his past history of stone, you know his family history of stone, and his metabolic profile. The next comes a set of laboratory tests. So history, laboratory test, stone analysis, radiology. Now in the laboratory test, there are actually 3 types of laboratory tests. So history, laboratory test, and radiology, it should be like that. The laboratory test could be either in the blood, what is called a serum laboratory test. You could order urinary investigations, or you could order stone analysis. So these are the 3 main laboratory tests when you have a stone patient. It doesn't mean that in every patient you will get to do all of them. But remember, when you order a blood test or a serum test, it's generally renal function test, in which what is important is creatinine and electrolytes and bicarbonate, whether somebody has acidosis or not, because there are some conditions where there is acidosis in the blood we are talking of, not urine pH. Urine pH will be later on, but like renal tubular acidosis, you will have acidosis and so on. Calcium test is important because hypercalcemia due to either vitamin D toxicity or due to hyperparathyroidism will present with hypercalcemia. Phosphate could be low in hyperparathyroidism and in phosphaturic states. Alkaline phosphatase is like a poor man's parathyroid hormone. So if your PTH is elevated, generally alkaline phosphatase is also elevated. And if you get what is called as bone alkaline phosphatase, then it is as good as PTH. PTH is 1500 rupees and this is 200 rupees. But then of course, PTH is PTH. When you want to diagnose hyperparathyroidism, you will have to do PTH. And then vitamin D3 test, which of course you can pick up hypervitaminosis D3. We discussed again last Friday, I spoke to you on how excessive doses of vitamin D3 can cause hypercalcemia and stone disease. And of course, in the blood test, obviously, in any stone patient, you will do uric acid. So any stone patients, and especially those who are multiple stone formers, you may have to choose from these serum tests. We move on to the urinary test. So urine routine is important. You will pick up infections. So you will pick up hematuria. But remember, you can have pus cells in the urine without any infection in a patient with staghorn. Don't treat with antibiotics. The staghorn guy or the multiple stone guy will always have pus cells in the urine. They are WBCs, but not infected bacterial WBCs. So therefore, unless your culture is positive, it is to be taken as just WBC. So urine routine. And then what is specific for stone patients is urinary metabolic investigations. And we will see again later on. I'm taking aram se more time because today we are having a lot of time to talk about. Otherwise, I'm generally very fast. So usually you should do it 6 weeks after the acute colic. We order what is called 24 hours urinary metabolic profile. We can also order a spot urine metabolic profile. Now, when do you order urinary investigations which are special or metabolic? It is especially done for multiple stones, recurrent stones, sorry. We should do it in younger people. I don't know what is happening. When you have a strong family history, when you're suspecting non-calcium stones, when you have associated renal failure, metabolic syndromes, diabetes, etc. In these people, it is better to order urinary investigations or urinary metabolic profile. As I said, you can do a spot metabolic profile or a 24 hours urinary estimation. And in urine, you order calcium, you order phosphorus, you order uric acid, urinary oxalate, magnesium, citrate, urinary sodium. Why do you order urinary sodium? Because you will come to know this guy is a salt eater. Why do you order urinary creatinine? Because you will know whether he has collected his 24 hours urine correctly or not. You also measure the amount of urine that he's collected. And of course, urinary cystine, wherever there is a possibility of measurement, not every center will be able to do all the tests. The most sophisticated lab is in Ahmedabad, where you have a stone analysis lab and a lot of people send the samples there. And lastly, the investigation of laboratory, apart from serum, urine, is stone analysis. Not every patient will bring in a stone and give it to you, okay, Baba, take this stone and do the analysis. Only 30–40% are able to catch the stone. And of course, when the urologist operate, then obviously they have the stone with them and they can do the stone analysis. And the last set of investigations, apart from history, lab test, is radiology, in which Dr. Badwe already mentioned to you the importance of IVU, CT scan. MRI is not much of use. So what's the algorithm for diagnostic evaluation? So every patient you will not do all the tests. So you could have either an abbreviated evaluation, short may, or you could have an extensive evaluation. Those who, as I mentioned in my previous slide, that there are certain people you will ask for recurrent, those who have recurrent stone formation, multiple episodes, family history, and all the metabolic fellows and many others with extensive evaluation. While single episode without much risk factors, abbreviated, shortened evaluation. But remember one thing, that there are two important things. One is his urine collection has to be proper. He has to be told by the laboratory or by the doctor as to how to collect the 24 hours urine. And the other thing is you must discontinue any medications that interfere with the metabolism of calcium, oxalate, uric acid prior and during the investigations. And you know a lot of drugs which interfere with calcium, oxalate, uric acid, and so on. So those drugs should not be on board when we are doing the metabolic investigations. So the diagnostic evaluation of nephrolithiasis, how do you do? I know it's a dry subject, but it helps if you can. It's not very difficult. Economically, it may appear initially expensive, but if you can prevent recurrent stones, then it becomes economically viable. And it will give you information of selective rational therapy as to kisko kya dene ka. For example, those who form alkaline urine, usme if you give alkalinizers, it is useless. And those who form a lot of acidic urine, alkalinizers will help. So diagnostic evaluation may either you will do the abbreviated short protocol or extensive protocol or a simplified metabolic evaluation, depending upon what it is. So let's take Raju. Raju is a 23-year-old man who comes with severe colicky right flank pain, vomiting, not associated with any urinary complaints, pain subside with medication, a plain non-contrast CT or an ultrasound, something was done, and a 5 mm renal calculus was there. He has no significant past history, family history of stone disease, karmic pehle se kuch likha nahi hai, what next? I think abbreviated protocol should be enough. So single stone former without increased risk, no family history, no past history. You just go into the detailed history as we mentioned earlier. You can do a blood screen. We just mentioned what blood test to be done. You can get a urine examination done. You can do radiography in the form of an ultrasound or a non-contrast CT. And if you pass a stone, you can do a stone analysis. So much for the abbreviated protocol of a asymptomatic chota stone form. In the history, what did you ask? Basically, what is his age, what are his dietary habits, what is his drinking habits, is he able to drink a lot of water, hydration status, and whether there is a family history or a genetic predisposition. You also ask in the history his bowel habits. So those who have say malabsorption syndrome, short bowel disease, obesity, pediatric, they tend to form calcium oxalate stone. In the history, you can ask whether he has a lot of joint pains, and whenever he eats non-veg, he gets a toe pain. Whether he drinks with his friends, he gets a typical gouty food, and so on. Patients with diabetes and other metabolic syndrome, you can pick it up from history. You can ask for a multi-channel blood screen. Jaisa bolte na ki we just ordered a metabolic profile. So a simple blood screen will have renal chemistry. In that renal chemistry, you must have creatinine and you must have electrolytes and you must have a bicarbonate. This carbon dioxide, basically what he means is bicarbonate. And you can have calcium and uric acid. This PTH is optional. You don't ask for in an abbreviated protocol. PTH is only when you suspect something, if you have hypercalcemia then. For certain systemic problems like primary hyperparathyroidism, where you have a high calcium, low phosphorus, that is the patient where you will order a PTH. Other patients in uric acid, you will obviously do a complete uric acid analysis. Now, some metabolic profiles, as I told you, they have distal RTA, distal renal tubular acidosis. There you have a lot of nephrolithiasis, nephrocalcinosis. In these patients, potassium will be low. Metabolic acidosis will be there. What about urine routine? This is, I think, urine analysis. So urine analysis, if your pH is more than 7, it is suggestive of either an infection stone or of RTA. So RTA, the urine is unable to be acidified by the body. And that is why the pH remains always beyond 7 in a renal tubular acidosis. But if the pH is less than 5.5, it suggests a uric acid stone. So in these patients, stone analysis will help whether what type of stone it is. And of course, this is the typical urine routine showing different kinds of crystals. Now, this question is always asked when you take a class on urine analysis and you see crystals in the urine, what is the significance? So crystals in the urine are commonly seen in my urine, your urine, anybody's urine. If he drinks less water in general in summer, crystals are fairly common with whatever food you eat and so on. But in a stone patient, it becomes important as to the type of crystals, and these are the appearances: envelope shape, needle shape, rectagon, hexagon, etc. And some labs only are able to pick up the stone based on the crystal types. The next thing, from urine routine, you move on to urine culture. Here you do it, urine culture, you do it for anybody who has a stone disease and is infected, because calculus disease will make you prone to develop infection. Whether you have a bladder stone, you have a ureteric stone, you have a renal stone, stone is a foreign body, or a stone is actually an external item, which I think, again, external item is not the exact word, but it's something which can make you prone to develop a urine infection. But there is a special type of stone which is infection related calculi. Those are different. So signs and symptoms of fever, shivering, dysuria, loin pain, etc., pyelonephritis, calculus pyelonephritis, and so on. In fact, some of the stone patients in a diabetic make them prone to emphysematous pyelonephritis and so on. So if culture is positive, then you treat with appropriate antibiotics. And many infected calculi will harbor bacteria even after treatment with broad spectrum antibiotics, and these stones will have to come out. In fact, as Dr. Badwe mentioned, that if you subject them to lithotripsy, some of them, they can release large quantities of endotoxin and endotoxic shock and so on, a vascular collapse or a septic shock. So some of these infected stones could be dangerous. From labs, you move on to radiology, and in radiology, there is plain X-ray KUB, there is IVP, there is CT scan. If you already know somebody who's got a stone disease, then plain X-ray KUB is okay. You can find out either stone, especially large stones and all, radio opaque stones. It's easy to make out. The radiolucent stones you will miss. The ureteric stones you may miss in about 20% of the patients. But they are useful in picking up nephrocalcinosis, tag-on calculus, etc. And again, you don't need to subject them to a CT scan. So 90% of urinary calculi are considered to be radiopaque. The sensitivity and specificity of KUB X-ray is poor. Only 45 to 60% you'll be able to pick up. But once you pick up a shadow, 70 to 80% of the times it is specific towards a stone. But ultrasound is important, and it has high sensitivity for renal stones. But again, poor sensitivity for ureteric stone. 19% of the ureteric stones will be missed on ultrasound. But if the ureteric stone is large enough to produce hydronephrosis, then ultrasound, again, this is hydronephrosis. So then it will be good. This is renal stone and this is hydronephrosis. So there must be some stone below. And of course, it is an image of choice in pregnant women. Patients in the pediatric age group, as well as those with a history of non-radio opaque stones, again, ultrasound better than plain X-ray KUB. We move on to IVP, and nowadays a lot of people do CT IVP rather than the simple traditional IVP. But an IVP, Dr. Badwe mentioned, is important at times too. It gives you information on the size of the stone, the location of the stone, radiodense, what is the anatomy of the calyx. The urologist wants to know all of these. The degree of obstruction, what is happening to the other side. If you have a single side stone in the ureter and the other kidney is either absent or small, it's a single functioning kidney which is blocked. There is an emergency. It's a urological emergency, a nephrological emergency. Then ureteric calculi can be distinguished versus non-urological radiopacity. So if you have a colic and you don't know, the IVP might pick up a ureteric colic. But remember, any IVP, before that, you must do a creatinine. You're listening to a nephrologist, but today, you don't need a nephrologist. No radiographer worth his salt, no radiologist will do an IVP or a CT with contrast if you do not have a creatinine. And if your creatinine is more than normal, he will not do, and you should not send the patient for an IVP. So to reduce the chance of nephrotoxicity, what you can do if you're ordering a IVP. So firstly, these are the patients you must be careful. Those with CKD, those with diabetes, because the dye is very viscous, and those who have a vascular disease have more chance of developing CKD. Dehydrated patient will develop AKI. Congestive failure, old age, hypertension, these are all high-risk people. Anemic patients, if your LV function is poor, they are similar to congestive cardiac failure. That means the actual flow into the renal blood vessels is less, although the patient may appear in fluid overload. So minimize the amount of contrast material that is to be infused. And if you have to do consecutive studies like they do today, one CT after the next day again CT with contrast, today IVP, next day again a contrast, or for whatever reason, then keep a gaps to allow the kidneys to recover. I think this is about, one second, what is this? I think it's about CT, the non-contrast CT. Non-contrast CT is used for assessment of stone size, shape, number, location, and it is more than 95% sensitive and specific for urinary stone. It's expensive, but far superior to a plain IVP or a KUB or an ultrasound. It tells you the location of the stone, but more important, the density of stones in Hounsfield units, which the urologist wanted to know. They can make out whether it's a hard stone or a soft stones, a calcium bearing stones or not. Whether there are secondary signs of hydronephrosis, whether there is a renal enlargement, is there pyelonephritis, what is called as periureteric or a perirenal fat stranding, and hydronephrosis, which is mild to moderate, can be picked up. Also, a CT scan will rule out a gallstone presenting or mimicking like a ureteric stone. A CT scan can rule out an appendicitis. You can also get an idea about the renal parenchymal thickness when you have a hydronephrosis. MRI is hardly used. Stone analysis in those patients where you can collect a stone, you can do a stone analysis and find out what is the type of stone, which helps you in giving a diet and alkalinizers, whom to give, whom not to give. What about from abbreviated? Is Dr. Badwe going to show the video? Can somebody find out from him? Because then I will not go so slow and I will want to then hurry up with my presentation. Anybody, Dr. Nilesh or anybody can find out whether Dr. Badwe is going to show the video? Anyway, so if you have a case which is of recurrent stone formation, there is a strong family history. If you have metabolic disease, solitary kidney, children having stone, renal insufficiency and stone, in those patients, those who have a higher risk of repeated episodes, you may do extensive diagnostic evaluation. And by extensive diagnostic evaluation, you may have to do 3 24 hours urine samples are collected. The first 2 are obtained on a random diet. Remember that immediately after the colic and all, the patient is generally on a very strict diet or is hardly eating anything because of pain, vomiting, etc. So immediately after colic is not the best time to do the urinary test. How do you collect the 24 hours urine sample? It's very important. So you must choose a day when you are going to be at home all the time, so that all the voids can be completely captured in the can which is provided on that day. So first you discard the early morning sample, since this represents the urine from the previous night. And then from then onwards, keep every amount of urine that you are passing in the lab provided container, which has a preservative or ice, and keep it till the next day. When the patient awakens on the next morning, the first morning void is collected along with the rest of the specimen. That is how a 24-hour sample is collected. So first sample, supposing you start collecting on Sunday morning, the first sample which contains Saturday's urine is to be thrown out, and Monday morning's urine, first time you get up, is to be collected. So extensive diagnostic evaluation. So even we find it difficult to do. We refer to specialty labs, and there are abroad a lot of stone clinics where all these extensive diagnostic evaluations are done. In our country, as I said, Ahmedabad is one area where this specific lab collects and does a lot of urine estimations, blood estimations, supersaturation index, and so on, which can actually pick up whether you are hypercalciuria, what kind of hypercalciuria, absorptive hypercalciuria, resorptive one, whether you have hyperoxaluria of what kind, and so on. So in the urine, we discuss what you do. You check the urine for calcium, for oxalate, for citrate, for the total volume in 24 hours, for the amount of creatinine, for the amount of sodium, for the amount of magnesium, for the potassium, for the pH of urine, for the uric acid and sulfate. So all this can be checked in the urine if you have the facility. So stone analysis, as I said, you do it in those where you can get the stone. So if you have calcium hepatite, then renal tubular acidosis and hyperparathyroidism are more likely. Uric acid, then gout. Struvite stones are basically in infection, and cystine stones are in cystinuria. What about a small stone of less than 5 millimeter? Should you treat how should you treat? This is a typical case of a stone which is small single or multiple renal calculi less than 5 millimeters. The necessity of treating such stones which are asymptomatic in a prophylactic fashion. So supposing you choose to treat it conservatively, like Dr. Badwe said, that up to 6 millimeter, you can attempt conservative treatment. Then it's important that the patient is explained that you need a regular follow-up and a metabolic evaluation. Those patients which are asymptomatic, some of them will need to be treated, like asymptomatic calicial stones in those who are in children, in solitary kidney, in pilots and Navy, he said, women who are considering pregnancy, or those who are symptomatic but mild symptomatic, dull pain, etc., but recurrent and bothering, those people you can treat surgically. So what's the treatment? The treatment mainstay of conservative management is the forced increase in fluid intake to allow a urine output of 2 to 2.5 liters. So there will be a revision of the diet in stone patients. We had done it in a very passing manner in the diet lecture when we had a panel discussion. So what does increased urine output do? It has two effects. One, it causes diuresis, obviously, and this is not the same as forced diuresis, which you try in hydrotherapy, where in one day you give 8 pints and diuretics and all that. This is just the standard increase in the urine output. The dilute urine alters the supersaturation of the components and reduces the supersaturation in chance. Plain water is your best liquid. We discussed in our herbo minerals that a lot of coffee and tea might increase the oxalate. Same is with the beer, wine, cola drinks. Certain vegetable smoothies, if you remember my talk of herbo minerals, I had mentioned the smoothies and the stylish diets which are being prescribed again has a lot of oxalate. So if you consume it in large quantities, then oxalate stones. Lemon and orange juice can be used as adjuncts because they can increase the volume, but they will provide citrate, and citrate is good for the pH. It may be good for the uric acid stone. But remember that you must avoid carbonated drinks, high fructose drinks, apple juice, grapefruit juice. Again, remember in my herbo minerals talk, I had mentioned grapefruit juice is rich in oxalate. Certain mushrooms are rich in oxalate. So fructose corn syrup, and of course hard liquor again, although will increase your urine output, but it has again higher oxalate problems. What about diet? Other aspects of diet. So as I said, protein restriction. What does proteins do? Protein increases the urinary calcium, the urinary oxalate, and the purines, and that means uric acid excretion. It also decreases urinary citrate and makes it acidic urine. So all this becomes a nidus for us, making the urine supersaturated. The crystals can convert into stones. And we saw how the stones were formed. Similarly, avoid refined sugars and use of high fructose or fructose corn syrup. We saw that insulin resistance makes the urine oxalate or calcium high. Sodium, as I have always said, salt restriction. You know our slogan, ek chammach kam. It's basically not just for hypertension, not just for congestive cardiac failure, not just for renal failure, not just for fluid overload, but for stones also. Sodium promotes lithogenesis by increasing calciuria, cystinuria, and decreasing the urinary citrate. A low salt diet limited to less than 5 grams of salt per day, along with a low animal protein diet, moderate calcium ingestion will decrease stone episodes by approximately 50%. Again, I'm repeating, low salt, low animal proteins, more of vegetarian food, some amount of calcium, less than 1 gram or around 1 gram of calcium per day will decrease stone episodes by approximately 50%. Obesity, increased BMI, waist size, weight gain, it correlates with increased risk of stone episodes. And again, they have higher chance of gouty, diathesis, higher chance of uric acid, and less of citrate. All that makes you prone to. What about calcium? And this question has been asked repeatedly in all these sessions. Currently, this is the current thinking that moderate calcium intake is recommended. Older recommendation was to restrict calcium, but when you restrict the calcium, it led to an increase in the intestinal oxalate, and hence the calcium oxalate stone formation increased. It is said that if you need to give calcium, calcium citrate would be a good choice because citrate is stone-friendly calcium supplement. And we reach again oxalate every step. When you talk of diet, it is only uric acid and oxalate, uric acid and oxalate. We are not talking of calcium in the diet. So you are not going to avoid milk and milk products and so on. We are talking of only oxalate and we are talking of uric acid. Again, they play some role in it. So less than 10 to 15% of urinary oxalate is usually derived from dietary sources. But it is ubiquitous. It is found in a lot of vegetable matter. So you will avoid things which are rich in oxalate, like tea, coffee, especially black tea, coffee. And then, of course, palak and bengan and nuts and chocolates, beets and so on, which is oxalate producing. So we are almost kind of trying to summarize. We're reaching 4:36. By 4:40, 4:45, we have to wind up. Since nobody answered me about the video of Dr. Badwe, I'm still continuing it. So treatment of stone disease,
Yeah, sir,
it's ready?
Yeah, no, he has an issue of internet also now.
Okay.
So
let's
he
see.
has
So
joined and he has again left. So
okay. So if all of you all have no issue, only Dr. Badwe has an issue. If you have no issue with me, then allow me to continue the talk.
Yeah, sir.
Sure, most people don't have an issue with me, although somebody has done namaste to me one day. Yes, so treatment of stone disease. Let's take it. The general measures are excessive amount of water intake, low salt, low simple sugars, less amount of meat, more of Mediterranean kind of diet, which is almost like the Indian vegetarian diet, and avoidance of high fructose drinks. So this is the general measure. Now come to thiazides. So thiazides are best left for hypercalciuric patients, those with recurrent calcium stone formation. Along with thiazides, you can actually, with thiazides, you can develop hypokalemia. So give a lot of potassium. And you will see that potassium is good for stone patients. And that is why fruits and vegetables are good for stone patients. So high potassium, low salt, thiazides will work wonderful in hypercalciurics and recurrent calcium stone patients. The next important drug is called potassium citrate. All that you see in the market, Portrait, MB6, K-Sit, Gush Out, and many others, they are all potassium citrates. They alkalinize the urine and they give citrate, which is stone friendly, and they reduce the calciuria. So the calcium oxalate stone formation is less, calcium phosphate stone formation is less, and uric acid deposition is less. So that's the beauty of giving potassium citrate. So thiazides and potassium citrate also reduce bone loss. What does thiazide do? If it reduces hypercalciuria, that means it is not allowing calcium to be lost in urine. So it is conserving calcium in the body, and therefore bone mineral density will improve because there is more calcium available for the bone. Allopurinol or febuxostat can be given to reduce uric acid in the uric acid stone patients, especially hyperuricosuric calcium stone formers. Remember one of the slides showed that the nidus could be uric acid. Over that, there is a calcium stone formation. And therefore, those who are hyperuricosuric calcium, unko bhi allopurinol dene ka. So this slide is summarizing all the pharma treatment available. Potassium citrate kidhar dene ka? What does it do? It helps in alkalinization. Those who have hypocitraturia, you are giving citrate, and it inhibits calcium oxalate crystallization. So it is helpful in uric acid stone, it is helpful in oxalate stone, it is helpful in cystine stone. So give it a tick mark. Okay, citrate, potassium citrate is a good thing. Allopurinol किधर देने का? When you have hyperuricemia or hyperuricosuria. So आपने urinary uric acid किया और उसमें it is more than 600. That means he is passing a lot of uric acid in the urine. Give him allopurinol. If your uric acid is more than 7 in the blood, give him allopurinol. If he's a stone former. When do you supplement calcium? All those who have enteric hypercalciuria, because if you don't give calcium, the oxalate is absorbed and you get calcium oxalate stone. Captopril आजकल नहीं देते. It used to be given for cystine. Now we'll tell you what is given for cystine. Nowadays, for cystine, we give tiopronin. It is useful for cystinurias. We come to thiazide. किधर देने का? Hypercalciuria. All those who are passing a lot of calcium in the urine, you give thiazides. So calcium oxalate stone, calcium phosphate stone, ये सबको thiazide देने का. When you're giving thiazide, what is your problem? You can develop low BP, you can develop dehydration, you can develop low potassium, and therefore you must supplement potassium, fluids, and so on. You can increase the uric acid also with thiazides. So these are the problems of thiazides. Pyridoxine, again, it is used for primary hyperoxaluria. So there is a product called Portrait MB6. B6 is pyridoxine, M is for magnesium, and we are coming to magnesium. So magnesium is again like citrate, it is stone friendly. It is given in calcium oxalate stone. Now, whenever you are giving magnesium, you must not give it in renal failure patients, because magnesium can accumulate and it can lead to respiratory depression. Similarly, whenever you are giving thiazides in renal failure, it will not work. So no point in giving thiazides to renal failure. Methionine acidification, nobody gives. What are the recent advances? I have only 1 or 2 slides, so you must be tired by now listening to me. But so the recent advances, there's something called Oxalobacter formigenes. It's oxalate degrading bacteria, and it may help in prevention of calcium oxalate stones as per some initial studies. It may reduce your plasma oxalate and urinary oxalate. So people are trying this Oxalobacter formigenes orally to be taken in recurrent stone formers who form a lot of calcium oxalate stones. Similarly, some people use probiotics and intestinal oxalate binders. Ultimately, we are back to what Ayurveda teaches. The gut is the source of a lot of illness in human body. And in allopathy, now we have reached a state where a lot of illnesses are linked to gut microbiota. That's the new modern thinking in certain allopathic illnesses. I'm sure a lot of Ayurvedic practitioners would be happy to know that there I durustai, but a lot of us have realized the importance of gut and what you are eating, or in general, holistic care, or in general, lifestyle modification plays a big role in certain illnesses. And you will read in hypertension, you will read in diabetes, you will read in fatty liver, you will read in obesity, you will read in obstructive sleep apnea, CKD, the role of lifestyle modification. So in summary, ladies and gentlemen, and all my friends, urolithiasis is common in India and should be aggressively treated. And remember, this line is the take-home message for all that we are doing in the last, whatever, 20-25 lectures, that we have to prevent CKD. We want to stop CKD. We want to early diagnose CKD. We want to prevent dialysis and transplant. So to that effect, what can you do? You can only treat the treatables. And what are the treatables? The non-communicable diseases such as diabetes, hypertension, obesity, etc. Stone disease, recurrent infections, drugs, herbominerals. And these 5 or 6 things, if we take care, we will reduce the requirement for dialysis and kidney transplant in this country who cannot afford dialysis or transplant. So that is why this plea of not missing out stone disease. And that is why we have kept one full session on stone disease. So the second line of the summary, where is my cursor gone? Yeah, is that urolithiasis may not be just an isolated stone, but it may be a part of a bigger metabolic abnormality. As I mentioned about killing not two birds, but many birds with one stone. So pick up a stone and you will use it for many things. Hunt for the calculus. Look out for a family history, because then you know this guy is a dangerous stone former. Find out whether he's got a habitual low water intake. Job uska hoega to usko bol ढूंढ ले बाबा रास्ते में इधर भी कर ले urine, but drink water, water and water. See that if he is a high animal protein intake wala, reduces, make him vegetarian to a large extent. High salt intake is very bad. High carbonated drinks are very bad. When you are investigating a stone patient, you may have to do a few blood tests, a few urinary metabolic profiles, and stone analysis, especially for those who have multiple and recurrent stones. And the treatment is fluids, thiazides, allopurinol, potassium citrate, diet, lifestyle changes, and timely urology referral in those patients which cannot be treated by medical management. Thank you for the patient listening. And I think I've covered the medical aspect and diagnostic aspect rather in some details. Thank you. I'm open to questions. Nilesh Doshi, over to you.
Yeah, sir. Actually, it was your turn to sum up the things, but as you have taken the place of Billa, sir, I
Yes.
must.
So I think I have summarized in my last slide everything that I wanted to tell you today about stone. And if this slide is what you follow, then definitely you will want to not miss a stone patient. Try to investigate recurrent stone formers, try to medically manage it. And when the stone is bigger than 6 to 7 millimeter, more than 6 weeks have passed, patient is not passing the stone, then convince him to not lose his kidney, but try and get it treated by the urologist. Can we go back to, I think I will stop sharing the slides.
Yeah. If you will stop sharing, then Pallavi would like to share something.
Questions. So there are some 6 questions.
Yeah. So, but before that, I must congratulate you and I must thank you that at the last moment you have taken the session, and people and the audience enjoyed it very much, and they were saying that, sir, you please keep it up and do not cut short it. We are enjoying it.
Okay. No. But I'm not enjoying the fact that we started our first session with 186 people and we are down to 106 people. That means we were not very popular as the days passed, and the number of people gradually declined in terms of the participants, unless you are providing them with ready-made material at home to watch while they are also watching their favorite serial.
What happened, sir, that we were not supposed to give the link at all, but there was a lot of demand. That there is a lot of mismatch in the timings and unavailability and internet issues and
all. No. It's fine. I'm just joking because it's important that they watch it. Whether they watch it today, tomorrow, after some time, it doesn't matter.
So we have changed the strategy a little bit.
No problem.
We are giving the links to the delegates so they can watch it for another 2-3 days.
Yes. I think you should allow them to see it more than 2-3 days. It doesn't matter. We don't have what is called as intellectual proprietary rights. Education ke upar we have no rights. Let everybody be educated as much as possible. And that was the whole purpose for which, Nilesh, you started along with me the integrated course, correct?
And probably we are thinking of opening all the sessions after, say, about few days, so they can watch it again, they can revise it again, and then they can give a proper examination and certification.
Yes.
Uh,
So,
yeah.
shall we answer the questions, or there is something Pallavi wanted to say something?
Yeah,
Right?
she has already said that. I mean, the Himalaya company is one of the program sponsor over today's session, so that slide has to be displayed.
Yes, yes,
So
fine,
even
fine.
Dr. Shukla sir, whenever he goes, he can show it to that. Yeah, that logo branding was there in our
So
today's
I
session.
must say, before even I was a nephrologist, Himalayas existed. Like
Yeah.
the Himalayas existed millions of years back, the mountain. Similarly, I think in our country, Himalaya or Sistone has been going on for years together. Sistone has become almost a household name.
Yeah.
And I don't know whether you need to prescribe or I need to prescribe. Most patients are already on Sistone sometimes when they come to us. They have already been, somebody has told, or the chemist has given, or somebody has already started Sistone. So it's almost like what we call as a household name.
Yeah, yeah. So yeah, sir, let us start with the question answer.
Yes.
Yeah.
So I think, is that the first one? Vipul Kakkad, 4:20 p.m. No. Nilesh,
Yeah. It
is
was the
that the
first
first one?
question.
Okay.
4:20 p.m.
Stag on calculus more than 5 years, RFT urine normal, no hydronephrosis. Is there a need for surgery? How long we can wait? Is it mandatory to do surgery? Please guide. If he's a 75-year-old lady, why do you want to touch? If he's a 20-year-old guy, 30-year-old guy, young guy, the other kidney is also slightly weaker, you try and safeguard this kidney as much as possible. So there are many factors in the treatment of a case. The other thing is whether the stag-on is causing any issue in terms of recurrent urinary tract infection, etc. So the age, the comorbidities, how easy or difficult it is will decide. Obviously, for me, it is very simple. I will refer to my urologist to decide. But if you have somebody who's already bad kidneys, other kidney is also bad, patients always going into a chronic kidney disease and end-stage renal failure, then to subject that patient to a surgery and risk will be a problem. But otherwise, a stag-on in a young guy, maybe it would be worthwhile treating because now the methodology is available to treat. The second question, how many times urine is collected in 24 hours urine analysis? As I said, abbreviated ones, the detailed ones 3 times. But most people hardly give even once. So 24 hours, once, so definitely we do it, but 3 times is done in those who have recurrent stone formers, metabolic disease, etc., and in specialty clinics of stones. Why to advise urine test after 6 weeks? No. It's not urine test. It is urine metabolic profile after 6 weeks. Mainly any metabolic profile would mean that your diet has to be stable. That means you must be eating what you are normally going to eat even when you did not have stone. Because afterwards also, you are going to go back to your old days and your old style of eating, your old culture of eating. So we put you on a normal diet and then do it. During the acute colic, you are vomiting, nauseated, antibiotics, painkillers, your diet is less. It's not a typical standard one. So you wait for 6 weeks and then do it. Can you elaborate about Oxalobacter formigenis? Very little is known about it, except that it reduces oxalate formation, and therefore on a long-term basis, and there are just 1 or 2 studies, on a long-term basis, you can put patients who are on recurrent stone formers on Oxalobacter formigenis for 6 months, 1 year, 2 years, 3 years. We do not know. So we are still to learn about Oxalobacter, except that it has been shown to reduce the oxalate. Can hydrotherapy be used in ureteric stones? If yes, up to what extent? So hydrotherapy, as Dr. Badwe had said, that hydrotherapy can be used in the oral form. There's no problem at all because oral hydration is not the kind of forcibly giving a lot of fluids. Like the IV, where you give a lot of very fast IV fluid, and on top of that you give diuretics. So generally specific hydrotherapy is with diuretics, while the oral hydration, which you give 3 to 4 liters or 4 to 5 liters of oral liquids, is not the same as the IV hydrotherapy. So oral, yes. IV, now the present thinking amongst the urologists is to avoid IV hydrotherapy. What's the role of water softeners, mechanical, chemical in preventing stones or prevent recurrence of stones? So again, the scientific literature is still lacking as to whether hard stones are, the hardness of stone is an indicator of increased stone tendency. People were saying that because in Rajasthan, in Punjab, in all those areas, because there is hard water and there is higher stone chance, they were putting 2 and 2 together. But it's not proven that hard water gives higher stone chances, although a lot of people believe it. So I would say logically, yes, hardness of water and stone may be related, but in scientific parlance, no connection between the two yet. Is this COVID pandemic a patient who has a history of crystalluria and kidney stones? Is advisable to take vitamin D supplements to prevent and treat COVID? So if the vitamin D is grossly low, bring it up to normal. Vitamin D is not bad. Excess of vitamin D is bad. Why does albumin in urine analysis of renal calculus probably of calcium oxalate show? So whenever you have urine infection, you get albumin in the urine. Whenever you have stone in the kidney, there is breach in the continuity of glomerulus, and therefore proteins will be seen in the urine. Sometimes even from the tubules, a protein will come. So that will be mentioned by the urine report person as proteins positive. So breach in the continuity of glomerulus can allow albumin to go down. Till what time we can wait for a silent stone of 2 centimeters to operate to renal or ureteric? Ureteric, you can't wait unless the kidney is already gone. If the kidney is already gone, is a young patient, remove the kidney and the stone and the ureter. If the kidney is functional, then obviously earlier the better, you remove the stone. Whether on restrictions on milk intake are desired in urolithosis, we discussed that up to 1 gram of calcium is fine. Milk, as in routine milk ingestion, which a common man has it, no problem. But I think Sehwag, our opening batsman, used to say he used to drink 2 liters of milk. Then you don't need to become a Sehwag if you have a stone. So Virendra Sehwag jitna doodh nahi peene ka, but otherwise you can drink now. Whether any restrictions on milk intake, I think we just, is it safe to take beer for diuresis? थोड़ा सा beer पीने में हर्जा नहीं है, but again we talked of oxalate being a problem in these patients. 3 millimeter bilateral, one of patient having multiple to 3 millimeter bilateral can operate 3 times for severe colic. What should we think? So this guy should be referred to a specialized stone clinic, and you should do a metabolic stone profile in these patients. In 3 times of urine analysis, one is early morning, second is random one, and third one when it is taken. No. This urine analysis 3 times is a 24 hours urine analysis. How important is diet in stone formers? In uric acid, yes. In oxalate, yes. In others, it is okay. Calcium, phosphate, etc., not much. Where we can get stone analysis done, all simple labs will do a spectroscopic stone analysis test, but the specialized ones are available in Ahmedabad, and I'm not sure whether in Mumbai we have any. So the standard stone analysis done in any lab. It's about 150 to 200 rupees. It's a standard stone analysis. You can do it anywhere. One of the lectures, milk of magnesium Nicardia retard is advised to take for a few days. It's advisable. So magnesium is good. We just discussed if the patient doesn't have renal failure. Nicardia retard acts like a ureteric dilatation. Like you have Urimax or alpha blockers. Some people have tried using Nicardia retard. Again, not very commonly practiced, but maybe no harm. How long the stent can be left in the body? The standard stent is for 3 months. The silastic one for 9 months to a year. Role of tamsulosin in ureteric or renal calculus. Renal calculus, no role. Ureteric calculus, it tends to dilate slightly the ureter and allow the stones to come out. In hematology of renal calculi patient, what does increase RBC count and total leukocyte count and platelet count indicate? So it all indicates only your infection. Any infection will increase the WBC count and can increase the platelet count. I think this was the rapid fire round of question and answers.
Yeah, so it was answered. All the questions were addressed nicely, and I'm sure that to treat the stone, the diet is playing a very important role, and analysis of the stone and accordingly the advice of the diet, what we say is a pathya, uh, has been addressed very nicely and in very detailed way. So I suppose all are enlightened.
Yeah.
All must have been enlightened with this session. So all are saying nice session. Thank you very much, sir.
So I think enlightenment was actually Dr. Badwe was talking of how energy and spiritual aspects of different forms of energy and how it will pulverize your ego like it can pulverize the stone and so enlightenment उधर हुआ था Dr. Badwe का session. हम लोग का तो simple था. So no energy actually. Nephrologists hardly have, the urologists have all the energy, whether it's in the form of laser or it's in the form of ESWL. Well, anyway, but mine was a very long talk, so I hope people didn't get bored because there was too much material in it.
But sir, at the end of the day, what we need to understand and what is our goal is, even if we can save a single kidney after this session,
Yes.
of a single patient,
Yes,
would be a credit, first and foremost thing. Ultimately, that will help us in preventing the lives of the people. Any organ damage ultimately leads to the, ultimately it's life-threatening.
sure.
So it shortens the life of the person.
Yeah.
So what we have to focus is that what sir has said, including diet, drugs, and herbo-mineral. All these things we should keep in our mind and utilize it judiciously to save the kidney. And at the same time, ek chammach kam,
Yes.
sugar
Ek
and
chammach
salt.
kam. I want all the 300 participants in this integrated course to take up these two campaigns. Know
Yes,
your
sir.
numbers so that every patient of yours knows his numbers.
Sir, can we have one flyer of this and can display it to all the participants? And
we can, but flyers are generally kept there. Most people take it, and at the end of the day, when you go home, there is a lot of kachra in your waiting room and people have hardly read and done. But if you insist that every patient and his relatives को free में तुम BP अगर check कर देता है and whatever 50 rupees में sugar check कर लेता है and weight free में कर देता है, you've done a great service to the whatever. I mean, you can take 10 rupees for BP also. It doesn't matter.
सर ऐसा कुछ करे कि एक फ्लायर बना के रख दे लोगों को.
बना
देने
देंगे,
के
बना
बाद में
देंगे, बना
देने
देंगे.
के बाद में वो अपनी क्लिनिक में लगाया है कि नहीं उसका एक प्रूफ भेजे. तो ऐसे जो लोगों ने भेजा है उन लोगों की एक हम लकी ड्रॉ निकाले और उसमें से 5 लोगों को कुछ प्राइज दिया जाए.
Yes, we'll do something. We know Dr. Nilesh Deshi will come out with brilliant ideas, that much I know. So I will leave it to him how he takes it forward, the Know Your Numbers and the Ek Chammach Kam campaign. But it will do real service to the country if you can control the non-communicable disease epidemic. Okay?
Sir, in today's, before starting today's session, I have written one message into the group.
Yes.
That myself, Dr. Khanna sir, Dr. Ojha sir, and Dr. Badwe sir have worked at one place for many years.
Yeah.
And it is my pleasure to present all these my seniors in front of you. No?
Anyway, so I am quite happy, Nilesh, that you have done this, and I'm sure even you will take these two campaigns into the Ayurvedic fraternity, and after all, you all believe in it. Lifestyle is your way of treating. Holistic care is a way of teaching. So it's easy to convince you people than convincing my own fraternity the importance of all of it.
So we will do something, and we will have some special prizes for that also.
Sure. Thank you so much.
Yeah. So I will request Dr. Vinayak Desai to have a vote of thanks.
Yes, Vinayak.
Dr. Vinayak Desai, please.
You need not thank us, both me and Nilesh, because we are part of the.
Yeah.
Yes, Vinayak. I think he's muted.
Yeah, no, he's unmuted.
He was there. I just saw him.
Yeah, he is there. He is there. He is unmuted also. His video is off at present. Dr. Vinayak Desai, please. Yeah. Yeah, vote of thanks from your end. Dr. Vinayak Desai. He is also one of the very eminent and very active member of our organization.
Yes, Vinayak.
Yeah.
Yes, Vinayak.
Please convey your vote of thanks, Dr. Vinayak Desai.
He is unable to reach us.
He is unmuted.
Yes. Vinayak. I think his network issue.
हाँ डॉक्टर विनायक भाई वोट ऑफ थैंक्स बोलो ना.
नेटवर्क इश्यू लग रहा है.
हाँ अभी बोलिए, चलो अभी आप मालूम पड़ गया ना, आप अभी बोल दीजिए.
Am I audible?
Yes, you are.
Audible?
Yes.
Good evening to all respected doctors. It's my privilege to give vote of thanks in of such dignitaries. Of two dignitaries, my father was under the treatment of Dr. Umesh Khanna for 15 years, and the fistula was done Dr. Badwe, sir. I'm very grateful to you, sir. Thank you very much, sir. First and foremost, I thank our today's speaker, Dr. Umesh Khanna, sir, and Dr. Shrikant Badwe, sir, for giving the knowledge about management of stone disease. We're grateful to this course mastermind, Dr. Umesh Khanna, sir, and Dr. Nilesh Doshi, sir, for designing, and also enlightening us the topmost doctors across the nation. On behalf of Ayurvedic practitioners, I am Dr. Dilip Trivedi, sir, Anawat, sir, Dr. Sanjay, sir, Dr. Sir, Yogesh, members for their unstinted efforts for this event. I thank all the delegates for giving valuable time. Also, I thank Mumbai Kidney Foundation, Parul University, National Sushrut Association, and last but not least, Association of Ayurvedic Practitioners. Thank you very much.
Thank you.
Let us not forget Maharashtra Council of Indian Medicine is also one of our co-supporting organization, and it's one of the the prominent council. It is, I suppose, the topmost in all these 5 organizations. That council itself is supporting this event, so we must not forget that council also.
Sure. Thank you.
Thank you all.
And of course the audience. Thank you.
Yeah, of course.
Okay. All right. Thanks, Nilesh. Chalo.
So anything else? So Pallavi, anybody wants to say anything? Surjit madam, Neelam madam, Vinay bhai.
Sir, it's always a pleasure and a privilege to be a part of Association of Ayurvedic Practitioners. And it's a feast to listen to Umesh sir, Badwe sir, And sir, we appreciate your efforts to bring everyone under one roof. Congratulations, sir, for such a successful session. I appreciate it wholeheartedly. Not only me, I think so, complete Ayurveda fraternity along with the allopaths, I think so we all are a family now. Thank you so much.
Yeah, for me, all these are the family. Like we have had our lunch together for many a times with Dr. Badve sir, Dr. Umesh Khanna sir, and Dr. Umesh Oza sir, because all three were and myself were at Bala Hanuman Hospital, and no, they were coming to operate with their dabba.
Lovely, sir. Very nice.
Yeah, so we were used to have lunch together for many a times. So they are very close to me for years together.
It is a great appreciation, sir, for all of you under one roof. Congratulations. It's a great success.
Yeah, thank you. Thank you.
Thank you.
Yeah, welcome. Pallavi, you can close the session now then.
Okay, sir.